Long Court Syndrome (LQTS) Part 1.
Let's look at all the pictures on the slide. Do you know what they have in common?
All of them are related to long QT syndrome.
Great. Here's our first picture. What can you say?
In 1957, Jervell and Lang Nielsen described a Norwegian family with 4 of 6 siblings affected by sensory neural deafness, significant QT prolongation and recurrent syncope starting in early childhood, resulting in the sudden death of 3 of the children. Congenital causes are usually a result of mutations in ion channels, potassium, calcium, or sodium, with more than 15 identified mutations.
Great.
Long QT syndrome affects males and females in equal numbers and has been identified in all ethnic groups.
What does it mean 1 to 2,500?
Disease prevalence is estimated at close to 1 in 2,500 live births.
A 21 mean in connection with FT syndrome. It can often be a lethal disorder, and symptomatic patients left without therapy have a high mortality rate, 21% within 1 year from the first syncope. However, with proper treatment, mortality is now approximately equals 1% during a 15-year follow-up. QTS itself is not the problem. Many people with the syndrome don't have any symptoms. Risk factors for long court syndrome: electrolyte imbalance, hyperkalemia, hypercalcemia, hypomagnesemia. Underlying heart disease, heart failure, hypertrophic left ventricle. Inherited genetic mutations. Anorexia nervosa. Bradycardia. Drugs. Hypothermia. Increased intracranial pressure. Post-cardiac arrest syndrome.
Do you think this picture will help you memorize the risk factors for long QT syndrome?
Rather yes than no.